Okay.
Hello?
We're ready? It's not. Is that ready? It's not? Okay, welcome everybody. Maybe grab your seats, and if you need to get tea or coffee, you can discreetly sneak out and bring it back. My name is Rhonda Cockrell. I am the director of IHPME at the moment, and I would like to welcome you all. We started planning for this, and we thought maybe we'd get 30, 40 people, but we've been completely sold out. I think there's more than 150 people who've registered, so that's amazing. I think it's really, we're touching two topics that are very important to people, sustainability and patient and caregiver involvement, and how those two intersect. I'm going to start with a land acknowledgement. So we acknowledge the land that we're meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Hu and Osaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is governed by Treaty 13 with the Mississaugas of the Credit. Now, we have a very busy afternoon ahead of us, so I'm not going to really spend much more time. I'm going to hand this over to Fiona Miller. So Fiona Miller is a professor in our department, and she has really kind of taken the initiative in terms of getting us involved in sustainability issues. And we're now, we have all these initiatives and committees, and there are a host of other people who've been involved. And I know that Fiona's going to recognize some of them, so I'm not going to do that. So basically, welcome. We're delighted to see everybody here, and I know Fiona's got a busy afternoon for everyone. So, over to you.
Thank you so much, Rhonda. I'm Fiona Miller, and let me add my welcome and thanks. It's wonderful to see so many faces here, those I know, those I don't know. As Rhonda said, we started thinking about this, and this room is going to be too big. And then we started thinking maybe it was too small. So thank you. So I'm here. I'm not going to take much of your time. I'm here going to be facilitating our afternoon. I got to give you some critical information. You've already found the food. The facilities, there's a women's bathroom and an accessible bathroom just out the door to the right. For the men, and larger washrooms for women, straight down that back hall and down the stairs. The other critical organizing information I need to give you is we're filming this event. We are filming at the front, and all effort is made to avoid filming any of you, but only in the front opening and the closing, so it's being live webcast now and will be preserved for posterity. So those are the organizing features. The other two things I want to do is explain why we're here and how we're going to take up our time. So for me, this event was really inspired by the wise words of a couple of health system leaders that we spoke with bit more than a year ago now, asked by Health Canada to engage with health system leaders to say, what would it take for healthcare organizations and their leadership to start seriously prioritizing things like climate change, which is a very serious concern that we have. And we heard that this isn't a priority, which was not terribly surprising, that public policy in general, whether it's for energy, transportation, or infrastructure, or supply chain, is not calling for the public sector as a whole to really think seriously about environmental sustainability. And healthcare policy largely ignores these questions, which makes it very hard for those within leadership or management positions, or patients or clinicians, to shift the conversation. But they said, if patients, families and caregivers said that this was a priority for healthcare, that would be a very important intervention into our efforts. And so I think there's two messages there for me. One, obviously, if patients, families, and caregivers take up this question, then this is going to be an important part of addressing environmental sustainability questions. I think the other thing, less obvious in their comment, is that, to paraphrase our Prime Minister, it's 2019, and if we're going to seriously attempt to make reforms and revisions to healthcare services and systems, then we need to engage patients, caregivers, and family members as partners in that process. So, 2 committees at the Institute that Rhonda has, where's she gone? Has championed and supported in her amazing way. One focused on patient and family engagement, and one focused on environmental sustainability, have collaborated to host this with generous funding from the Ontario SPORE Support Unit, which is the support unit for the strategy for patient-oriented research. So we're bringing together 2 communities who haven't worked together that much. So what are we hoping to accomplish? Well, one clear thing is learning. We really think that there's a lot of opportunity for all of us to learn and learn from each other. We think that environmental sustainability people will find it important to understand more about patient and family engagement, what it is, how it works, what you do, what you don't do. We think that many patients and families and caregivers will be interested to learn about the environmental sustainability challenges facing healthcare and what can be done to change. And we have 2 fabulous opening speakers to help us to understand some of those issues. But we also here are to make you all do some work, to borrow from your energy and your knowledge and your enthusiasm to help us to think about how do we bring these issues together. So we have a breakout session, and you've all been assigned to tables. They're color-coded. It's a bit of a crowded room, so we're expecting that you have 2 co-facilitators. Again, the entire event is organized around this principle that we're bringing together experts with knowledge of environmental sustainability and experts with knowledge of patient leadership, patient partnership for change. So you have 2 co-facilitators in each of your groups who are going to help you to think about what are the opportunities for collaboration? Where are the synergies? Where are the sweet spots where improving some aspect of healthcare's environmental impact also makes things better for patients? What's the low-hanging fruit, as it were? And what should we do, what should we not do if we're going to collaborate together? Okay, so I'm almost finished. So we're going to learn lots. What are we going to do with that learning? We will be preparing a report. All of you will get that report, and we'll digest from that report things more pithy, and we'll try and make it more broadly available in terms of media, what we can do in terms of communicating with healthcare managers and with the wider public. But it's very much informing our efforts within the Institute to think about the role that we can play. We're at a critical point in thinking about how we, as an institute, as a university institute, as a servant of the public interest, how we can support this mission. And with that, I want to introduce our first speaker, who, despite the time difference, is joining us from England. Can you still hear me? Rachel Stancliffe, who's the founder and director of the Centre for Sustainable Healthcare in the UK. Rachel has been working at the intersection of health and the environment for the past 10 years since she founded the centre in 2008. So it's more than 10 years now. She's interested, because of previous work of all sorts of interesting things, in using evidence and creative partnerships to achieve change. And her team at the centre is supporting healthcare in the UK and collaborating with us internationally, including being an important source for us here in Toronto to take a leading role in transforming healthcare. She's the founding director, not only of the Centre for Sustainable Healthcare, but of the Community Interest Company and Global Healthcare Information Network, and she's on several boards, including, importantly, Patients Know Best, Oxfordshire Local Nature Partnership, and the Climate and Health Council. So Rachel's going to speak with us for a bit. Thank you so much, Rachel.
Can you hear me? Yeah? Cool. Hello, everybody. I'm going to share my, my screen with you. So, wow, that looks like an amazing room. I can see lots of ceiling and not many people. Hello. Excellent. What a beautiful room. That looks like a lovely place. How are you all today? Good, excellent. Well, if there's any problem with the sound, just let me know. Otherwise, I'm going to share my my screen with you. So I'll say goodbye for now, and I'll see you back at the end. Okay. So, what do I do? Is that working? What can you see? Is that okay? Excellent. Okay. Well, hello everybody, and thank you very much for inviting me to speak with you. And I'm really looking forward to sharing a few things with you today, but also then collaborating into the future as well. So, now, how do I do this? Okay, good. So, as Fiona said, we set ourselves up about 10 years ago, and we are an NGO. So we work collaboratively with a lot of different organisations, not just research organisations. And we're really, we call ourselves a think and do tank. So we do some research type work, but we also do a lot of work on the ground. We are very evidence-based with what we do, and we run many different kinds of programmes. So I'll talk to you about some of those today. So I'll start with a very a broad introduction to what we think of as sustainable healthcare, what that is, what it means to us. And then I'll also talk about how we make healthcare more sustainable and give you some examples of what we've done. So I think this is the same in pretty much every country in the world. The healthcare challenges we have in this century are economic, they're social, but they're also environmental. So there are obviously different problems in different kinds of countries, but actually all of these things are really important. And we can't have health for our country and our people without at least beginning to sort out some of these things, because populations are increasing, social problems and inequalities are arising, and as we know, the environmental challenges are becoming really acute. So why should healthcare worry about sustainability? This is kind of, a starting question, I suppose. If you talk to a doctor, they think health people should be worried about health, but should they really be worried about how to keep the healthcare system sustainable? Because climate change is a big health threat, absolutely. And the link with health has been made very clearly by many people over the last 10 years or so, including people at the UN and WHO. So climate change is definitely a health threat. I don't know how many of you have heard of this Lancet Commission on climate and health. So they wrote one of the early paper on climate change being a health threat, but then a couple of years ago, they published this other response, which was basically turning it around and saying it is a big threat, but that could mean that it's a really big opportunity as well. So the things which are threats, we turn into positives, and actually the things that we need to do to stop climate change destroying our health are the same things that will improve our health anyway. So things like eating less red meat, reducing pollution from fossil fuels, and basically involving all the people in healthcare in making a sort of leaner, greener system will improve health as well as keeping this system itself sustainable. So there's a really good film there, and I urge you all to have a quick look at that. That bottom link there. So the bigger picture, I suppose, is not just the health system, but how we fit into the global system. And of course, putting people at the centre, we have these various layers around us that we are semi-aware of all the time. But when we have something like climate change, which threatens one of those big layers, then we begin to think more about these different interactions, I suppose. So I like this system, and sometimes when I'm talking to eye doctors, I'll start with just an eye in the middle, because obviously doctors are quite often focused on one part of people, not the whole person even. But it's really important to kind of take that broader view and consider where we sit within the natural environment. So climate change is a big health threat and or opportunity. Healthcare also contributes to climate change because it has high carbon emissions. So roughly equivalent to, I'm sorry, I should have added Canada onto this list. It's terribly rude of me. This is just my a couple of examples, but so greenhouse gas emissions in the US are about 10% of them come from healthcare, and it's about 5% in England. So it's roughly equivalent to the amount of your GDP that you spend on healthcare. So it's a big emitter, and also, sorry, I was going to add to that. It's not just about, obviously, about carbon emissions. In this country, for example, we know that a lot of our surgical instruments are made in bad conditions in Pakistan. So they're made sometimes by children, not often, but sometimes by children in terrible conditions for people who have very little pay, less than $1 a day and absolutely no labour rights. And so we are buying equipment and medical devices, things like that, which are made in countries which don't have very good ways of looking after the people doing that work. So in some ways, we are responsible for buying that stuff, and we should have care over the supply chains. So this is just to say that I'm aware that sustainability isn't just about climate change. It's about much more than that. It's one of the things that we need to look at. Number 3 on this list is that we have legal reasons to worry. So internationally, there are many attempts to set limits on climate change, set limits on carbon emissions, so the IPCC work and so on. And in this country, we have the 2008 Climate Change Act, and we have the Paris Agreement and so on. There are legal agreements which help us in some ways to define the problem and to act together on it. And obviously some countries are better than others at doing that. Not naming anybody. So the 4th reason that we should care about this is that resources are limited, of course. And we all recognise that, but I think when we're in a healthcare sort of situation, we tend to push that aside because we're so focused on health and getting better and helping other people to get better. So some doctors think that it's actually unethical to think about resources when you're treating patients, because that means that you're not giving full care to your patients. So I think later in the day, that's a good one to discuss, in the sense that, the individual versus the whole, and how much resource you can give to one person at the detriment to everybody else, and so on. So that's a sort of ethical issue. But given that they are limited, sustainability can improve the way that we use them. So this is one of the ways that we look at that. We look at value, or good quality healthcare being a measure of the outcomes, which we say must be informed by patient values, sort of divided by the incomes. So given the inputs of environmental, social and financial resources, what outcomes do we get? And this, underneath here, is what we call the triple bottom line. So that's to say that the cost of doing something is not just to be measured in financial terms. We can print more money. We can, our money is variable. It's kind of like magic beans, I always say. It's not a real thing. Whereas the other resources in here are real. People are real, the social costs are real, and the environment is real. And so we have to start measuring those properly. Otherwise, we're not actually taking care of what the costs are. So the way that we kind of look at that is is in this sort of simple Venn diagram, and I quite like this because it enables us to look at what is actually the sweet spot in the middle there, which is a combination of social, environmental, and economic value or resource use. So now I missed the intro because it was all muted, so I couldn't really hear. But I'll talk and I don't want to bore you with this because it's sort of focused on the clinical side. But bear with me because it kind of explains the logic behind what we do. So if we all agree that we want to reduce carbon or environmental costs without reducing health, then how do we do that? We can either treat fewer people, okay, we can reduce our activity, or we can reduce the carbon intensity of what we're doing. So we use this sort of driver diagram just to break down the logic of that. So how do we reduce activity? We could just say goodbye to every sort of 9 out of 10 people who walk through the door, but we don't want to do that. So we have to say that we're treating as many people as we can, continue to treat people, but we have to have a much bigger focus on prevention, on self-care and patient empowerment, and on lean pathways to reduce activity. Then to reduce the carbon intensity of what we do, we have to have lower carbon alternatives, and we also have to have sustainable buildings and processes. So again, maybe later in the day when you're focusing on the different, I think we're having a session on the different levels of at which you can work, the personal, the system, and the design system and the processes, then you might think about this thing again. Because for us, this has been important in terms of defining different ways in which we work with different parts of the system. So I hope I've given you sort of introduction to sustainable healthcare as we see it. There's loads of different other ways that you can look at this, obviously. So I'll talk now about how we've kind of focused on making healthcare more sustainable. And this is an ongoing process. Nobody has the answers. So we've got some ways of doing things and we're learning all the time. So that's what's part of the joy of all this. So first of all, what do we need? We need leadership and advocacy, and we need a lot of patience. Not patient, we also need patience, but we need patience because it's a long slog. And 11 years ago when we started, I really thought that we would be able to shift things in a major way within 5 years. And I was so wrong because it's you have to persuade people of the need for this as you're going along. And I think at the moment, actually, we're in a very exciting time when people are really beginning to get this. You know, the plastic in the ocean type discussions have really made a difference to how people are engaging with this. But it's the first step is to engage people. Then we've also got to understand the footprint. So we've got to be able to measure stuff and understand what's going on. And then, of course, we've got to work with all the people involved on the ground in changing those things. And then we've got to train the people coming through the system, and so that they can carry on and do those things as well. So I'll talk briefly about some of that. Not all of it, because we don't have time really to do things in depth. But I'll talk to you a bit about how we measure things in England at the moment. So this is the carbon footprint of the health service in England. And of course, we're lucky that most of our health service is provided by the state, so it's fairly easy to get an overall picture. Would anybody like to guess what the majority of this comes from? You'll have to help me because I can't see everyone's hands. How many hands are up? Can anyone guess what this large blue chunk is? I can't hear anyway. Okay, so basically, when we first did this work back in about 10 years ago, we were really surprised by this because I think everybody thought that the big buildings in healthcare would be the biggest use of carbon, right? You've got those boilers, you've got those massive hospitals and so on and so on. But actually a huge chunk of the carbon footprint is from procured goods. So that basically means drugs, medical equipment, linen and things like that. So it's not mostly in the buildings, it's mostly the stuff we use when we're doing healthcare. And that's really important to understand. And of course, everyone went, oh, but we're not like that. Our hospital's not like that. But of course, when it came to looking at things in more depth, actually, they are all like that, or nearly like that. And it depends on the service. So different services are very different. For example, dentistry may be very different from surgery. There's a lot more travel in the dentistry. So this is interesting anyway, and we've got to do more of this, finding out actually what's there, what is the picture underneath, because as we know, carbon is invisible. And I'm talking about carbon, and I hope you don't mind me simplifying this sort of environmental sustainability like that, but it's because really it's very difficult to start measuring everything. And this is one thing which has begun to be measured in different ways. So we've got a bit of a grip on it, but it's not to say that it's the only important thing. So we kind of looked at that graph and we thought, okay, I mean, pie chart, and we thought, actually not much of that is to do with the actual building. Most of it is to do with the clinical care. And most of that footprint can be affected, changed by how we do our healthcare, how the systems are designed, how our patients are involved, and so on. So this is just another graph showing some of those hotspots, and you'll see there the primary care pharmaceuticals one is actually the biggest one. So the drugs that are given out by what we call GPs, so family physicians, in primary care are actually the biggest chunk of all the carbon. So that means the biggest set of resources, which is quite surprising to people usually. And we can talk about more of that later if you like. So another example of a hotspot is inhalers. So did you know that the meter dose inhalers, which are the ones which are gas propelled, are 11 times higher emissions than the dry powder ones? Again, we don't really think about this. We think about just taking what we're used to, or the GP has the doctor has a preference for one or the other. But these are examples in a way of things which we can do something about, which certainly don't negatively affect patient care. So how are we getting on? In this country, not terribly well, although we've levelled off rather than increasing our footprint, despite all the voices about an ageing population and so on. But there's good work happening. This curve just shows you really how far we've got to go to reduce our carbon footprint. And I think, again, as with measuring things, it's definitely worth keeping an eye on where we are, encouraging ourselves when we're doing well, and speeding ourselves up and being more urgent about things when we think we're not going enough. So I won't dwell on that now. But the other thing I mentioned earlier is that we need in order to tackle this big issue is everybody around the table. So we've always tried, when we've started working, to think who to involve, and we've tried to involve pretty much, a representative at least from every one of these areas, because unless you get all the voices involved to sit around and discuss what the solutions might be, then really, or even what the priorities are for tackling, then you can't begin to work properly. So engaging all these different types of stakeholders and working closely with them all, I think, is really, really important. And there's one of our round tables. They will look very young to me, but it's just my age. Okay, and then the last thing that we need is well, not the last thing, but the other thing we need is education and training. So we run a sustainable healthcare education network. We're working to integrate sustainability into teaching and training and and continuing professional development as well. We started with some background work, and that involved basically talking to the General Medical Council about sustainability, and eventually came to last summer, hooray, after about 7 or 8 years of working with them. We basically had this in the new outcomes for graduates. So this is something which everybody has now got to do. So in a sense, you have to work with the policies and the paperwork, which is then a lever to pull things through the system. So this is an example of that. So now that we have that in place, we can go back and we can do some master classes and training of the people who need to teach those things, so the educators. And that's one of the things that we'd like to work with you on. So I've talked a bit about how we make healthcare sustainable, and I'm now going to give you a few examples of the work that we've done ourselves. I mean, most of that stuff we've done, but I'm just going to try and give you a more in-depth example, maybe. So this is how we started. We basically started thinking about how do we make healthcare sustainable, and we thought, actually, we can't do it by looking at the buildings, given the carbon footprint. And without the engagement of professionals and patients, we can't make proper change on the ground. So how do we engage them? What's the kind of program of work for doing this? And we decided to work with communities of practice, or based on clinical specialties, because basically if you're a patient, you are being usually, I mean, this actually varies because you may have multiple issues, but most patients are seen by specialists in a particular area, and or GPs, but primary care physicians, I mean. So we work in this way with specialties, and we take a person out of that specialty because they, from the inside of that community of practice, understand how that community works, they understand the language of that community, and they understand the issues, both on the ground and coming down on them from above, which I think is really, really important. We skill them up in sustainability, and they create within their specialty a network of champions. Those champions are based in places on the ground, so in hospitals and community centres and so on. And they themselves will do action learning, so they will try things out and write up case studies about what they're doing and share those with other people in this network. At the same time, we're doing research, which may be with different sets of people, or including them as well. And we're creating knowledge and tools to help all of this network to grow together. So it's quite a sort of organic process, and it does take a while. And at the same time, the fellow might be working nationally or internationally to sort of create some of these policy levers and changes which we think are necessary to shift the whole system. We can come back if you want to ask questions on this at the end. So the one we started with was nephrology, partly because my medical director was a nephrology specialist. She'd come out of that to work with me, but also because it's a very resource intensive specialty. And also because it's quite long term, so we felt we might get a good engagement with groups of patients as well. So we had a fellow, and we set up this network, and in the first year we had representatives in about 80% of the renal all over the country. We ran a summit. We had an award program to sort of encourage good practice and good case studies, and and we were also doing demonstration projects and research at the same time. So this is an example, a very sort of tech example to start with, and it was based on I don't know how many of you know dialysis and nephrology, but it's based on how you do the dialysis on site. So some people bring in acid canisters to mix with the water, and they bring them in kind of plastic plastic kind of containers, basically. But there's other ways of doing it. You can do it with dry powder, or you can do it with central acid delivery. So this one was shifting from canisters to central acid delivery. So it takes some upfront investment, but then actually the cost savings are about 20,000 a year. So within 2 years, you can see that that's paid itself back. That's a very technical thing. And there were quite a lot of those because it's quite a kind of technical specialty in some ways. So we had a lot of lab technicians and things working with us as well. But we also did this, for example, looked at the carbon footprint of home versus in-centre dialysis. And we looked at, for example, telephone clinics in follow-up of renal transplant recipients. So this is just to show you, really, not to focus on any of the specifics, but just to show you that there are lots of different things that came out of this work, and there were actually hundreds in the end. And the aim then is to share them and spread them across that network. So patients were involved very right from the beginning in the green nephrology work, and one of the main ways, obviously, is in actually making a system more lean, is not to think about the system as it is now, but to think about what do patients need from it. So patients' lives can obviously be improved if they don't have to travel so much. So that might be, combining consultations, or it might be the home dialysis if you're living very remotely from your centre, or various things like that. It's certainly these days is following up things by telephone and by computer rather than by getting the patient to travel in. Patient care can also be improved by allowing them to take a more active role. So often, of course, patients have the best chance of making a good decision about what they want from their care if they're well informed. And the patients know best thing that Fiona mentioned at the beginning that I've been involved with is a very good example of records which are visible to everybody. And basically the patient can see records going between different caregivers within the system. And it actually really, really improves the care, but it also improves the efficiency of the system. Because the patients care most about their own health, really. I mean, you can expect your caregivers to care about you, but you care the most. So the person who set it up is both a doctor, a patient with quite complicated health issues, and also, luckily, a computer buff. So he was able to pull those skills together and create this really good platform. But we've also obviously had to focus on prevention. We would like to focus more on prevention. And getting patients involved is a really good way of doing that, because obviously you're a patient now if you're within the system, but nobody wants to be a patient. And so helping the system to think about how to change can be really helped by having patient involvement. So the cumulative savings we made. So this was basically a bit of research pulling together that we did, which looked at some of the green initiatives that had come up from our network. And we took 6 of those innovations and we thought, okay, what if we do them in 30% of units? And we took 11 kind of other types of innovations, and we looked at what if we do them in 60%. And actually these were the savings we could make. So, and we're a small country, those are small examples, but actually it demonstrates that you can do a huge amount of saving, both for the environment and money-wise, and actually that those things nearly always have patient benefit. So it's worth digging down, it's worth understanding where resources are spent, and it's worth thinking about the pathways of care that we have at the moment and whether they're really the best ones. So we've got many networks now in lots of different specialties, not all of them by any means, but another example is in eye health, and this is a much more recent one. So we set up a working group which includes researchers, patients, industry, and so on. We work very closely with the Royal College of Ophthalmology in the UK, and we run sessions at their conferences every year, and we have a prize that we run. There's a network set up, and also we've been doing some kind of more systematic analysis of these pathways with one or two eye hospitals in the UK. And more excitingly, at the end, in a way, we've got a new app for sustainable cataract surgery. So that was funded by an international NGO, the International Association for the Prevention of Blindness, who work all over the world. And actually, they're really supportive of this because, again, they can see that it will help people, doctors and patients, to learn from one another in different countries in the world and to share best practice. That's good, not just for the environment, but also for those patients and also for those health systems. So we've got four fellows at the moment. Well, 4 areas of fellows. And we have scholars as well sometimes when we can't afford a full-time fellow. So that's a couple of them in ophthalmology, working on lots of different things. We have other programs around that main kind of core of clinical program, which basically help us to engage with the hospitals and the other healthcare professionals on the ground. So one of them is the Green Ward competition. And that means that's where we go into a hospital and we give workshops and encourage the wards themselves, so people within the wards, to come up with good ideas about what they can change. So this is not sustainability specialty focused. It is just sustainability on the ground in a place. So it's place-based, really. And we're running this in about 5 or 6 places at the moment. And sometimes these things cross over with our specialty work, but it's a really, really good way of just engaging people. So we have a workshop at the beginning. The teams run the projects. They learn how to measure things in terms of carbon and other environmental resources. We go in and judge that competition. And that's good as well, actually, because it brings in the sort of top people at the hospitals. And quite often, you'll get the chief exec or chief medical officer along to that judging, and you'll really spark their interest. And they'll go around the wards with you and they'll say, oh, wow, I didn't know we were doing this, or I didn't know we could do this. Or so it's sort of way of doing innovation, I suppose, which helps them obviously then. And then we share. So sharing and communicating all of the good stuff is really, really important. So, okay, we don't need to go through that, I don't think. Another of our programs is the NHS Forest. And the aims of the NHS Forest were really to improve the health of staff and patients and the wider communities around those places, through increasing access to green space on or near to NHS land. So it's a really good way of bringing green space to the fore and helping health professionals and patients to use that green space better. We've also got, the main sort of hook, I suppose, was to plant 1 tree for every staff member of our health system, which in our country is 1.3 million. But actually, the planting of the tree is a kind of symbolic thing. It's really about engaging people. And so we've got a very, very nice project at the moment, which is staff at mental health hospitals taking patients out for walks at lunchtime. And it sounds so simple, but I went along to a patient day at the Royal College of Psychiatrists here, and the stories of people who've been patients themselves in some of these places not being allowed out because the staff weren't available, or being given drugs instead of being taken outside because people felt it was safer for them, or just the sort of continuing stories of what I saw as crazy use of resources, really. not giving people access to the outdoors and to what is naturally healthy. So there are some good ways that we can begin to reverse that. And I think that, again, I don't know in Canada, but I hear it's certainly growing, that movement of kind of connecting back with nature and connecting healthcare professionals in with that work, which I think has a lot of potential. So here are some examples, and Bradford did some nice walks. University Hospital Coventry involved their local school children, as you can see, early on in understanding about connections between health and nature. And Nottinghamshire actually did a really nice program with people who weren't able to get employment, helping them to learn skills on their site and then go on to get jobs in those areas. So you can use those outside programs in an awful lot of different ways, but connecting them back to the health site and connecting the messages very clearly with health messages is a really good opportunity, I think. We've sort of grown the NHS Forest project, and it's now become, as I said, about walking and about doctors giving green prescriptions and designing health routes with us and involving the whole community, basically. So that's a really good sort of positive story. So I think that's probably it from me. I just wanted to say thank you very much for listening to me. I hope I haven't rabbited too long and too quickly through that, but I wanted to leave some time at the end for questions, if that's possible. Yeah. What do? Stop sharing. Is that right?
Thank you so much, Rachel. Questions? Oh, yes, thanks. I always forget the critical thanks part of these things, but questions? And we'll run around with microphones.
Otherwise, I'll ask you questions.
Oh, yeah, right. There you go. There's one back there.
Hi, Lisa Van Lint. I'm here from University Health Network. Oh, sorry, highly unnecessary microphone for me. Lisa Van Lint from University Health Network. One of the things that I saw, I was very interested in the procured goods as being a major part of carbon emissions. But the other thing, we have, one of the things you mentioned was talking about for hemodialysis. And can you hear anything? Not at all. Okay. Hopefully somebody can type this out. But the hemodialysis system, we used to...
You can hear them.
Sorry?
I will try.
Okay. So the reason I'm bringing this up is I'm hoping in this very large room that maybe somebody is here from Accreditation Canada. The reason being that we used to have that system. It was very successful. A lot of people loved using it. All of our medical engineers loved it. We did save environmental elements, financial elements, all of these good things. But then we have to get accreditation, and accreditation decided that we would lose points for not using new materials. Yes. So I'm really hoping somebody is here from Accreditation Canada, because I would love to change this rule. Because of course, all hospitals need accreditation points. Anything that causes them to lose points is going to be something that will not happen. And that's what happened with us, as well as other hospital systems.
Yeah,
yes, I've typed something.
Maybe could somebody come up if they're asking questions?
Oh, there's a good idea. But Lisa, this is about procuring goods to some extent, right?
To some extent, it's procuring goods, but to other extents, it's dealing with other elements of healthcare. Because really, I was just noting about procured goods being very interesting, right. But the issue being hemodialysis and having the system of the sort of the centralized distribution system, really good system. And then what happened is
accreditation.
Sorry?
Contravening the requirements of accreditation.
Exactly that.
Right, so the critical issue is that we have accreditation standards which may in fact get in the way of some of these innovative changes. I think the example was Green Nephrology, and it was an attempt to create a centralized capacity, and that ran afoul of accreditation, and of course hospitals need accredited. So I think a general question is perhaps, I mean, Lisa's asking, is anybody here from accreditation standards? And
I'm kind of hoping.
Right. Something to work on, but maybe a general question is, how have you faced that sort of problem?
Yeah, absolutely. So, I mean, the one we're dealing with at the moment is infection control, I think. So that's come up again and again, which is a similar thing. It's basically, you know, if you want people to be encouraged to reuse instruments, for example, surgical instruments, and to be able to sterilize them, but there's been this huge push from industry, really, and therefore it's been built into the kind of health and safety mantras that hospitals have, that actually single use is much safer. Now, that has not been necessarily built on evidence, but it's there in the culture, and it's there in a lot of guidelines. So I don't know if that's a similar thing, but it's kind of, you have to then at some point tackle that issue as a whole, rather than just coming up against it all the time. And another one, which is a similar one in a way, is kind of talking about perverse incentives in the system. So, for example, that telephone clinic thing I talked about, it makes complete sense for the doctor and for the patient, but the system was not being paid as much for doing telephone clinics as they were for doing face-to-face. It was a huge difference. It was like £20 versus £160. So there was no incentive to change. And so again, there you've got to go back and you've got to say, why is that there? Can we change the rule to allow this to happen? Because otherwise we're stuffed, our hands are tied. Yeah.
So we've got a question here. Charlene, do you want to come up here? Can I ask you to do that, just so that then I don't have to badly translate what it is you're asking? Charlene Wei.
Thank you, pretending to be the speaker. It's Xiaolin Wei from the IHPME. So thank you very much for the great presentation. And I think it's really great to take a series about patient engagement into the process. So my experience here, for example, in Canada and also in China, we have done letting patients into the decision-making process to decide if they are going to use antibiotics or not. So that has hugely reduced overuse of antibiotics. And there's other things, for example, like treatment adherence, if we can communicate with...
Turn around and talk to the microphone, otherwise I can't hear you.
Okay. So my question is really about, how seriously we can look at patient engagement in terms to reduce the overuse of medical resources. It has been proved effective in for example, prescribing of antibiotics or use about other things to support patient adherence in diabetic management or in the tuberculosis management, etc. So I would like you to explore a little bit in terms of this kind of patient involvement, not only for what we talk about, but I'm more looking at, for example, it's going to reduce the overuse of medical resources.
Okay, so if I've understood, so to what extent can patient involvement help to reduce overuse and over
Misuse, like antibiotics was a great example. Yeah. Diabetes care, other examples. Yeah.
Yeah, and it's so interesting because I think this is it is shifting, and I think it's a lot to do with how patients and doctors have evolved their relationship over the years, and this very paternalistic in a way relationship that was there for many decades. About the doctor knows best about everything, and the patient is there to be told what to do. And because of technology and because of much better sharing of knowledge, I think that has changed. And we can definitely, as a patient, I get involved as much as I can, as much as I have time for in my own health. And I'm sure most people do these days. So definitely engaging patients and helping them to understand the issues is a really, really important thing. And I think, the medical professionals maybe underestimate sometimes how much patients know and understand and want to be involved. And that's something that we have to work on changing gradually.
Anyways, right.
Yeah.
So you have a choice to come up here and ask a question if you don't mind being filmed, or asking it via me. So did you want to come up, or have another question? We have a time for a little bit more. Thank you for this glitch, managing this glitch. Thank you so much.
Sorry.
Thank you. My name is Sal, and I'm a caregiver advocate. I became one after looking after my parents and my father-in-law, all of whom had long and painful deaths and took a huge toll from the family. As a result of my advocacy for parents and for caregivers, my big concern is the climate change, but not the natural climate change, but the social climate change. Everybody knows that we're living in a society now, there are more older people than younger people. We have an aging population. In 7 years or so, the first of the baby boomers, millions of them, will start crossing the 80-year-old threshold. Now we know that all of them are healthy and will live long lives, and none of them will die. So the issue is, how do we prepare for them? Because there's a tsunami coming. And so there's a social climate change challenge that we must also deal with. I admire everything that you're doing, and I hope we will do the same for the natural and physical environment. These are pressing issues, but so is the social issue that I would like to draw attention to.
Thank you. Yeah, this is a challenge, isn't it? There's so many important issues, so many critical issues we need to work on.
Thank you very much for that. And I mean, so I'm a demographer by training, actually. So that was where I started. So I'm very much with you, and I can't believe really how people kind of stick their heads in the sand about demographic change. You can see it coming for decades, and we don't prepare for it. So it's definitely one of the crucial factors in climate change as well, and in sustainability.
Gosh, I think we can take one more question. I think this lady over here, and then we're going to move on, but we'll have some more Q&A later. Thank you. Please introduce yourself.
Hi, my name's...
You might need to actually hold this so she can hear you, because this is the problem that we're having, is Rachel can't hear.
Okay.
Thank you so much.
Hi, Rachel. My name's
Hi.
Tess. Hi. Oh, and can you see me?
She can see you if you're right here.
If I'm... Oh, okay.
This is the problem. This is looking at you.
Hey. So my name's Tesla Latouche, and I'm in the healthcare space as well. I've actually been working on a system-wide change model, a reform model for healthcare here that's actually really pushing the bleeding edge of what we call sustainability, and functional and regenerative medicine is being the focal point of what this sustainable model looks like. And just to your talk, I didn't hear you really mention anything around prevention and how you're working towards, it sounded a lot around, disease state management and working from a centrally managed space, and, some stuff on the green spaces, but prevention and sustainability of like the self as an internal customer of this sustainable model. What does that look like for providers and practitioners? How are you driving accountability around this whole preventative mindset? And yeah, I'm also going to share, I'm on the Global the Global Wellness Institute Women's Leadership Initiative. I am on their committee. It's the foremost leader in evidence-based wellness research in the world. And I'm very much an advocate and a pioneer on what sustainable healthcare can look like. So I know that the UK is ahead of us. What are you doing on this sort of piece?
Great question.
Okay, well, brilliant. Thank you for your question. It sounds like we need you on our team.
We can talk about that after.
I mean, so basically, I came from public health, and I And I see the prevention part of this being, well, that should be led partly by public health. I think with the trouble, what we've decided to do, because the system is so skewed in its resource use to the what I call the deep end, so when things have already gone wrong, we decided to work in that deep end rather than standing upstream where I would like everybody to be and sort of waving and saying it's great up here. Partly because, in a very sad way, I recognised coming from public health that actually it's a poor cousin. I wouldn't call it sister. It's a poor cousin, and it's very badly resourced. And actually, the people in mainstream, as it were, deep end health, do not respect it sufficiently. And so our feeling was, understanding that dynamic, that we had to kind of jump in the deep end with the, where the money's spent in order to make our voices heard. And I hope that this process is partly dragging all those people out of the deep end and upstream towards prevention.
Okay, great. Okay,
but it is, I'm sure you've heard lots of stories. There are really scary things about which aren't being done about prevention, which could be done. So yes, I'm totally with you, and we are trying to include it. But I look forward to working with you more.
Super. Thank you so much, and I'm so sorry we're going to have to call this to a close. And
thank you.
Okay. Thanks so much.
Thanks, and bye-bye. Good luck with the rest of your day.
Yes, it's late now, isn't it? So we'll let you go. So
Thank you.
I'm delighted to be able to introduce our next headline speaker, Emily Nicholas-Angle. Emily is a patient leader who's been helping bring the patient voice to Canadian healthcare for over 10 years. Her journey, as she says, has taken her through the ERs, the ORs, the MRIs, and many acronyms in between. And these are the kinds of experiences that have led her to be critically interested in how patients can become partners in their own care and in health system improvement. So she's sat on the board of Patients Canada, is one of the founding members of the Patient Advisors Network, and she's consulted quite widely, very widely, on patient and family engagement with hospitals, with government agencies, with research institutes, with other organizations across the country. She also has brought this expertise into her professional work. She's the Director of Health Engagement and Communication with Reframe Health Labs, where she specializes in bringing the patient perspective to the lab's evidence-based approach to health and wellness communication. So thank you so much, Emily.
Hi, okay, first of all, I'm just going to make sure that I know what I'm doing here. Do I just click or press to the right? Okay, oh, yes, there we go, it works. Hooray. Hi, thank you for that great introduction, and what a great event today. I see so many people that I recognize, actually, and also people that I don't, which is super, and there we go, I am. Thank you. Basically, I'm going to talk a little bit today. We sort of thought we'd do a little bit of patient engagement 101, I'll call it, or some intro, and then hopefully get into some of the issues around sustainability and how we can lead into the next discussion. So I like to ground, whenever I come and do a talk, or grounded in sort of a little bit about my experience, and sometimes I feel like it's like I have to prove that I'm a patient, but I don't feel that way. I just hope that this can give some sort of grounding to what I talk about next, and also potentially feel free to ask me questions at the end. So I come to this patient engagement world from basically someone who didn't have much health care experience until I was about 20, when I had a misdiagnosed injury, which people thought was a muscular issue, and it turned out was actually a small stress fracture from a repetitive injury. Now, after some misdiagnosis and some confusion, that ended up into a severe break, and I actually had to have a pinning in my hip done, a surgery done. Now, during that time, I was also at school and feeling, I sort of say I was a very stereotypical first year pre-med, as it were, wanting to be a doctor along with the 2 million other people in Con Hall at U of T, and thinking, here I go. And then life happened along the way. So after this surgery, things, you know, we're okay. I moved home with my parents, so I wasn't with my friends at university. My social situation changed substantially. I was in a lot of pain, and the first surgery didn't actually work to heal my leg. So they had to do something called a femoral osteotomy, which isn't as fun as it sounds, but they actually had to graft a piece of bone from one part of my leg into a different part so that we could change the fracture and all of these other reasons. But I ended up with what I like to call my Frankenstein hip, which looked like had bolts sort of coming out of it. And along this journey, I still was trying to go to school. Wasn't really able to do much with my friends socially. As I say, I was in pain. I was with my family all the time. Sorry, my parents. Not a typical younger person experience, and as you can imagine, that led to actually quite substantial stress, and I was someone who I think was predisposed to anxiety, but this definitely exacerbated it, and I started to deal with substantial mental health issues, depression and anxiety and obsessiveness. And what I noticed was that in my treatment for my hip, I was getting super amazing high-class clinical care, but not a lot else. Nobody asked me how I was doing as soon as I left the building other than maybe my physio. And that to me, that struck me because actually, you know what? My quality of life in many ways was more affected by those social and those mental health aspects than it was even by my acute issues. So I show this up here. I belong to a hip replacement support group, which, all to say, 8 years later, it culminated in my bone actually not surviving all of the damage that had been done, and my hip bone dying, and I became the lovely owner of a bionic hip at a very young age. So that's why I have these pictures up here. I belong to an online community, and everyone calls themselves hippies, and it's all like, peace, dude, and people ask each other questions, and I'm gonna revisit this later. But along the way, I also ended up, due to my anxiety and depression, needing some mental health care. Now, to get that mental health care, my family paid a lot of money. We actually took out a second mortgage to pay for it all. But within that care, all of a sudden, for the first time, I started thinking about not just not being sick, but actually what it meant to feel well. And things like, was I moving my body? Was I seeing friends? How was I thinking? All of these things, which actually I kept thinking to myself, this would have been very useful back in the day. So this kind of bringing together, I felt like there was these very disparate parts of healthcare. And in fact, this one part of healthcare that I was getting wasn't even available to me in the public system in the immediate way I needed it. So as time progressed, I started to think about how this experience, what it meant. I didn't feel actually particularly angry at the system, but I was interested in what I had learned and how that was applicable. And I happened to read about something called the Patients Association of Canada, and I will point out that Shalom Gluberman here today was probably one of my mentors at the beginning of this, basically sharing with me this concept that patients, not as advocates, but as more partners and as integrated members of the healthcare system, needed to have a voice, needed to actually share their experience so that we could change healthcare to actually consider all of these other aspects that I'm talking about here. And what does that mean? So, well, I would say at the beginning, when I met Shalom and started sort of volunteering with this organization, Patients Association of Canada, I felt like we would have to knock down doors to get into a conference. We would call them up and say, you know, do you have a patient there? Maybe we can get someone in, and we don't have any money, and they would let us go, and I would wait my turn before to go up to the microphone and say, did you talk to any patients along the way? And people would be like, well, you know, patients are at the center of everything we do, and of course we consider patients and lots of other words, and I would say, politely sit down, because I'm Canadian. I probably apologized and said, okay. And then move forward, this is what I feel like now. Now, I made this slide a few years ago, actually, probably, and I've updated it a bit, but, you know, I don't know if this is the Sistine Chapel or ET here, but people are taking this much more seriously, and it has actually become like an industry. This patient engagement world has felt like it has gone from, we kind of have, wow, we better embrace this at all levels and do this, and that's great, but I like to take a bit more of a skeptical view and to think about why in the first place are we even doing this? So what's all this fuss about? Where does it originate? I'm someone who likes to do things for logical reasons. I like there to be a grounding of some sort of reason. And although I believe in the moral and ethical reasons for doing things, I often need something a bit more. Apparently I'm not a moral or ethical person. So to go back to sort of what I learned a bit from Shalom, if we think about this shift in healthcare that's gone on over more than 100 years, but basically if we think back to when our healthcare system was built, it was built as an institution to deal with very pressing immediate concerns, acute care concerns. People didn't even live long enough really to be having those chronic diseases, and the leading causes of death were actually from acute issues, and we're considering things like these needles and pills and how do we fix somebody now? And move forward to today, where we look at the pressing concerns of our healthcare system, which is still really that acute care system, right? All the same buildings and well, not all the same, but many. But now people are suffering, people are aging to a potentially living forever, as this gentleman mentioned, and they're basically ending up with comorbidities, multiple chronic diseases. We see it younger and younger now. Less than 3% of the deaths are actually from the things that our system was built to deal with. And why does that matter? Why does that shift matter in terms of what our pressing issues are? Well, basically, if we think about this acute care model versus this chronic care model, we have to completely change the way we view how we see patients and the people within it. Because the treatment goals even are going to be different for someone who needs to be managing a chronic disease outside of when they go to the doctor and when they see someone at a clinic. They have to be managing outside of those places. They have to be managing in the context of families and dealing with people that are not just healthcare practitioners. And when we look at who it is that's actually doing a lot of the work, we can talk about caregivers outside of healthcare. And the patient isn't just receiving or basically receiving healthcare from the provider in a sort of one-off way where the plan is for them to be fixed. They're actually needing to implement tools to be activated, to be engaging in considering their health outside of the clinic. So this whole nature of chronic disease basically means that those formulas that people were using previously to deal with health, they can't really be implemented. We have to look at a much different model of what a person is and how they fit into the healthcare system. The actual experience of the patient is going to determine so much more about their health outcomes. And if we want to consider things like prevention and the management of chronic disease, we have to shift how we view that patient, not a passive person in the healthcare system, but as an active participant. And that changes completely how we have to look at the model. So there's also lots of other reasons that people give for why we do patient engagement, and often people will divide them up and they'll say there's sort of consequential ones and there's moral and ethical reasons and democratic reasons. I've listed a few here which I think are very important as well. One of them includes that, for instance, when we engage patients in research and in priority setting, we could potentially have more relevant outcomes for those patients. The problem is, as I'll get into later, a lot of these things are very hard to prove, to show. Kind of like how prevention, when we prevent things, it's very hard for us to show those outcomes and what we prevented. And I think this is, as I'll say later, one of the issues. But regardless of the actual underlying reasons for why we're engaging with people and caregivers and the public and patients in healthcare, patients don't really care why. They're just doing it. They're demanding it. And I think we see this, health isn't happening as driven by the patients. It's not happening just in the clinic. People are going elsewhere to learn about their health. They're finding other ways to deal with it. And as we know, a lot of real health itself doesn't even happen in healthcare institutions. It's happening outside those walls. And people are leaving healthcare institutions often, I know in my circumstances, not solely satisfied with what I was given and how I was supported and what I was learning. Now, we see this in something that people like to call peer-to-peer healthcare. I think this has been going on since the dawn of time, but now we have these other technologies that facilitate it and allow it. So going back to my hip replacement support group, I love this. You know, when I had my hip replacement, I took a lovely little one-day, half-day course in the hospital where I sat with mostly much older people, learning about what was going to happen and how to, you know, deal with physiotherapy after and those sorts of things. We didn't talk about a lot of the practical issues I was going to face once it was all done, or how to transition back to sort of living normally. As a lot of my patient engagement friends and colleagues, we like to call it sort of that gray zone where you're not acutely ill, so you're not getting lots of care, but you're not really well enough to feel confident and capable and supported outside either. And I actually find that the hardest part. So often people turn to things like this. Now this is that hip replacement support group I mentioned, and although you can't see it in detail, I'm glad everyone's already had their lunch. Basically somebody posted, you know, I had my hip replacement and I'm on these painkillers. When am I gonna have a real bowel movement again? And I love it because immediately, you know, there's like 64 replies and people are like, eat prunes and go to, this is the best, you know, stool softener and all of these things. And really, like, yes, thank you, because I really wanted that to be in my manual. And these are some things that are driven by the patients, questions asking the other patients, because actually we know from research that people trust in many ways, for better or for worse, that information often from their peers. Much more, not much more I shouldn't say, but often more, or at least equally to the experience and the expert-based instructions of healthcare providers. And so patients and caregivers have critical information, and I could go into this as a whole other topic about how they're driving research and various other aspects of healthcare on their own, not engaging necessarily even much with the healthcare system. And we see this with, you know, this can get touchy, but things like about access to medications and patient advocacy groups getting together. But there's a drive here that it's just a want. It's happening regardless of what the healthcare system does. So I think it's an opportunity, but also it's a necessity for us to start to embrace this. And to go back to something I mentioned before, when we look at this really built on acute care system, we also can look at financially how mismatched the spending is and how mismatched it is where we put our efforts when we know that the determinants of health fall into categories which include, you know, your socioeconomic status and where you were born and your language and how access to healthy food and these things. But actually we spend now this is American data, to be fair, so I've just nicely pulled it to prove my point. But I think, you know, it holds here. The percentages don't match up. And we usually talk about this, it's now becoming a much more accepted part of healthcare that we talk about these social determinants of health. And I would say over the past 10 years in my healthcare, I've felt it start to come into the healthcare system where people actually do talk to you about facets of your life outside of that clinical care. But again, we are being sort of pushed and forced to actually start to engage with people to understand their needs and experiences beyond just their sickness or their acute needs. So this is a slide from Zaina Kayat that I love just because it just squishes a fax machine. And basically, that we have to move from this kind of concept of a central institutionalized fax machine-based system to something that actually goes outside and integrates into communities and hears from the people who with lived experience. So these are all changes that have been going on. Health issues have changed, understanding of what influences health has changed, accessibility to information for patients. This means that we have to change the roles of the patients and the public. So if we go into some of the theory, you know, what do we even mean by engagement? Well, there are a few models. This is probably the most common one you will see, which is that there's sort of a ladder, or some people call it like a spectrum, or I don't even know anymore, I've lost track of what shape it is allowed to be, but basically we can move through sort of levels of engagement, of how we engage with people and we're going to talk about them a little later today, I think, when we break into groups, but basically from engaging in your own care, which I see as quite different, so the way you're empowered and activated to make choices within your own care, to then stepping outside of yourself a little bit more and sharing what you've learned and drawing on your experiences in a collaborative way to actually shape things. So this can move up sort of through the spectrum, and as we now sort of know, we try not to see this as sort of a hierarchy because different people are ready for different stages at different times, and I do think there's a place for all of them. But I think what we're talking about, that we're going to talk about all of them today when it relates to sustainability. So here's a more complicated version of the ladder, which shows, kind of those three levels, like engagement in your direct care versus in an organizational design, maybe a co-design, and versus sort of policy making, so shaping the system more broadly. And there's various factors that influence all of these, and we're going to get into those a little bit more later. It's also happening at different levels of healthcare. Now, this is just Canada here that I've given examples of, but I think now we know, some places are mandated. They're being told you have to have things like engagement councils, or you have to have people with lived experience involved in the design of your patient relations departments and things like that. I have mixed feelings about that sort of mandating before necessarily we know exactly what we're mandating, but it's going on. The Ontario government, I double-checked, it still says this on the website, that engaging patients and families at all levels of the healthcare system is key, and I do think there's, we can look at all the work of Julie Drury and the patients' councils and things that are going on there. And then, as an example, more nationally, we've got something called SPORE. What a lovely fungal name, but which basically is looking at patients as active partners in research, and I definitely do a lot of work with them, and that's a whole other topic. And if we go to even globally, we see, we had Rachel from England, there's been probably more previously had gone on in England. I think we're catching up massively. So, but even the WHO recognizes the integral part of engaging patients at all levels. And I threw the bottom part in there because I note that they also say that basically aligning with patient priorities is key to the sustainability of healthcare systems. So where are they involved? Sort of like how? This is a slide from the Patient Advisors Network that was mentioned previously, where we look at, what are the different ways that people can get involved? And this will span that spectrum or ladder that I'm talking about, presenting at conferences, I note, so as I'm exemplifying for you. But I do think that we're looking beyond these now. We're starting to try to think, what does real integration look like? And I think, what does sustainable integration and engagement look like? Because as I'll get into, it's a resource-intensive activity oftentimes, and it's going to need to be integrated in a way that can be maintained if it's not to be a trend that just dies out. So here's one of sort of the tricky issues, and I'll get into more, but we see this kind of difficulty in even knowing, I think this is what's interesting about mandating patient engagement, is we see conundrums come up like this, where someone is wanting to engage patients in their research, but are they working as researchers and partners, or are they being studied? It's actually really hard to tell, and our system doesn't necessarily do a great job to help you with that because things, and I'm not saying we shouldn't have research ethics boards, although apparently I did say I'm not very ethical or moral, but I will say that, sometimes, for instance, if you have to apply to the board to actually have those patients engaged in your research, but they're supposed to be partners, and you don't do that with your researchers, so what does that mean? I think these come up. And so that is the first of a few tricky issues, I think, which are important to acknowledge within patient engagement. One of them is, what do we even mean by patient and public engagement? And when we look at, this is from a paper, but basically, although we say it's relatively easy to sort of identify the benefits of patient participation, sort of generally, terms and definitions differ between countries. What successful engagement looks like is pretty variable. There's no broadly, I'll say, accepted. There are methods of evaluation that people have created, but nothing broadly created so that we can standardize and look across. It's not even clear how we exactly connect the dots from whether patients were engaged to better outcomes. So this is all some of the tricky stuff that we're going to have to reconcile as we start to actually make it a meaningful engagement of patients. Oops. The other one, and they love this word in patient engagement, but tokenism, which I think often does not stem from any ill will, but comes from that maybe previous comment about not really knowing what engagement necessarily exactly is and what it always looks like. Also, I think we can tack patient engagement and patient public involvement on as like an aside item, as opposed to actually put forward the time and resources that it often needs. And that can mean that people don't necessarily feel like their voices are being really heard, or they're not being listened to, or that actually what they contribute doesn't actually get integrated in. The other difficult, I think difficult piece, but an exciting opportunity and an absolutely necessary component of patient engagement, which will have meaningful change, is addressing the fact that opportunities for engagement and the ability to engage is currently, I would still say, not an equitable thing. The ability for me to come here today and participate, the things I get asked to do, it's mostly because I'm already kind of in with people. I already know where things are going on. I'm well enough to engage. I have the financial means. I do have a large mortgage, but all things considered, the financial means to be able to do this. And I think this is one of the areas we're struggling with the most now, is what does it even mean to have equitable sort of representation and involvement versus, we have a diverse sample, to go back to the research subjects, versus what does it mean to have the necessary voices at the table, and who are they, and how do we support them in the way that works for them? And this is where I think learning from lots of other people is always good. So the other part that I mentioned before is that it takes vast time and resources, often projects I work on, for us to do really good engagement. For instance, if I want to run like a co-design session, I'm talking to people beforehand, making sure they feel comfortable, making sure they know about, what's expected of them, making sure they tell me what they might need, then supplying those things. Or for instance, the other day, I had to figure out how to have the guide dog come, and it was much more fun with the guide dog. But these things, they take a lot of time, and I think sometimes we don't pre-plan for that, and it ends up often going back to the tokenism. That's where I do like this deliberative engagement sort of concept from Involve, which is out of the UK, but basically engagement has to be very context specific, right? Context dependent. We need to be looking who is it that needs to be at the table? Why are we doing this in the first place? A lot of the time we skip number one, and we go, yeah, and then we do patient engagement, and then what are we needing to do? Because that will help direct you in the way you engage and what you do. But as you can see, this all takes a lot of planning and time. The other thing that was mentioned previously was, trying to fit new ideas and new things into an outdated structure. To go, not just that acute care structure, but even just measurement, ways of measuring, talked about the research ethics boards and how you apply for grants, things like this, which weren't built to have patients included or patients engaged. They were built around a much different concept or model. And I find this one happens a lot. We still try to actually sort of measure and do things the old way, even at the risk of not actually learning anything, but instead of, so we're working on developing lots of new sort of measurement frameworks, evaluations, and a lot of co-design of those evaluations. And I'll call it co-design, a lot of engaging in what are we measuring. We talked about Accreditation Canada, we talk about it in research, and in lots of levels of the healthcare system. So there's this kind of knowledge to action gap. I think we know enough that we want to do the engagement, we want to partner, but there is a gap into knowing exactly how and also to doing it, to actually putting it into play. We do a lot of talking, like I'm doing now. I'm really good at doing a lot of talking. But we still, this remains to be seen, and I sort of just find a way to put this slide into every presentation I do. Just because his little toe, look at his little toe down there. Bridging this sort of the intent and the behavior gap. There's a lot of want to do it, but I do think sometimes we're reticent for the potential failures that we have. We're not really okay with it not going well, when actually most of the projects I've done where we didn't have things go perfectly, I've learned the most from the people involved. I'm going to skip over some of these other examples only for time's sake, but I'm happy to go back and talk to people after the break about some of them. I would say one of the things that I always have to remind myself is we're trying to sort of bring together the science and the art of this. I think both are going to be very important when it comes to patient engagement, because considering people as humans and considering people in environments and with their families and how we engage them and how we communicate, I do think will always take some form of an art. I think aspects of it, though, can be framed around a science. There can be sort of a skeleton structure, if we call it that, which we can draw on. And we're going to have to learn as we go, which is something which is tricky in healthcare. And I believe in evidence-based medicine, but I also know there's other things that ways that we need to learn and experience, and doing and learning by doing in these sort of lower risk circumstances at times is important. So now just a little bit about sustainability, and I'm going to sort of start it with just thinking about sustainability more generally, because I actually find that a really interesting conversation in the patient engagement community, which is we talk about engagement, and to me I think of engaging with like two things coming together. Yet when I talk about engagement, I often feel like I'm talking about the healthcare system needs to engage with patients. But there's not really any reciprocal responsibility on the other hand, and I feel like responsibility is an icky word with patients, and we don't like to say maybe partnership and shared decision-making and self-management and those things imply responsibility. But I don't think responsibility is a bad thing. I think it can be really empowering, and responsibility doesn't have to be just an expectation. It can come from the person as well who wants to take responsibility. So I think talking sustainability more broadly in healthcare and how we're going to have a sustainable healthcare system is something generally for patient engagement. And subsumed in there is environmental engagement. So yeah, patient engagement, woo. But then also I think, this responsibility and accountability, and I think the move towards having some more autonomy and all of it comes with some obligations and expectations, and that can be difficult, and that's where I think engagement also can be directive. I'm just going to return to this because I think it starts to tie things, is that I talked about this shift to chronic disease being a pressing concern, and I think, again, we see that as being underlying to how we have to look to prevention and to helping people self-manage and not falling into those acute scenarios to actually support sustainable healthcare. Now this is another one of those slides where I kind of I knew the statistic I wanted, and I Googled and I found it and made it work for me. So I don't know how good this data is. I did not go back in to look at it. It's from Carleton University, but basically I was thinking to myself, what does environment matter to me, or what does sustainability matter to me as a patient? And I thought, well, nowadays I'm relatively well, I do stuff like this, and I think about sustainability, and I think when I go, I don't want to use too many resources and too many, I like this idea about greening the hospital. If you had asked me when I came through Emerge, with a broken hip, about greening the hospital, I might have greened you a little bit, yeah. So I think we need to consider, as we talk about what people are willing to sacrifice and how people are willing to consider this, kind of where they are. And I thought this was interesting. When we asked people about the environment, only about half of them agreed that they do what's right for the environment, even if it costs more money and time. So sort of a little bit of work on their part. And I thought to myself, and that's people I'm assuming who are a mix of wellness levels. So what if you ask people who aren't as well? What are you willing to sacrifice in your healthcare? Now, I'm implying there that sustainability means sacrifice. It doesn't always. It sometimes is very compatible. But I'm talking about the discussion more broadly. So this is where, and I like to think about this hierarchy of needs when I think about engagement generally, because I think when we talk about where people are ready to engage and how, we have to consider where they are in terms of their healthcare sort of status. And I think we could overlay this with other hierarchies of needs in terms of socioeconomic needs and different things. But your ability to be concerned for things beyond the self and beyond your immediate issue is very much determined by your physiological state, and then maybe at the next level, your sort of levels of pain or cognitive abilities, things like this. And that's where I think it gets really interesting in how we approach sustainability with patients. How do we find this balance between considering what the patient's pressing needs are individually and this kind of greater good? And Rachel touched on this a bit. And I think, again, it's a difficult conversation, but it's why we need to engage in this kind of way, to start in places where people are at that stage so that we can start to guide those conversations that might need to happen in more acute situations or in more specific situations. And so basically, how does sort of engagement fit here? Well, this is an interesting quote that I found, which is sort of, we need to change this ethics conversation from what does this patient want to include how can we help this patient fulfill his or her sense of responsibility? Now, whether you agree with that or not, it's an interesting concept. And that the principles of environmental responsibility and awareness need to be built into the healthcare education decision at every level, I think is an important consideration before that. So if it had been built into the conversation at every level, if it had been part of the medical school training, if I grew up in an environment and was supported in a way that made that an accessible choice for me, it would be very different than being asked all of a sudden in the moment about whether I was willing to have the recyclable gloves or the, so we need to engage with patients, caregivers, and the public generally to understand what that balance is and to discuss that balance in an open, honest way, I think. I had to have one, so I hoped to include some examples here about that overlap and where it can occur much more synergistically, to use a lovely jargony word in there, and also at different levels. So I like the example of Choosing Wisely because I think Choosing Wisely's campaign and that organization has done a lot to engage patients in co-design, and they've done a lot to look at how do we facilitate actual conversations between healthcare providers and patients about making wiser choices and choosing less and when is appropriate. And that kind of conversation, I think, can happen in more areas than just that clinical care. Some of these have already been mentioned, but I'll just throw out end PJ paralysis, which I was reminded by a fellow advisor, Barbara, that I think is a great example that came up recently in an Andre Picard article. I know I can throw that name out in this environment and people know who that is. So, but an article in the paper basically, and discussing how patients being able to wear their own clothing and not wear hospital gowns and get changed in the morning, and what that does to actual care, but also how that overlaps with sustainable practices in healthcare. And I think Rachel gave some other great examples of those overlaps between patient maybe driven or patient-centric choices that we could engage with patients around that are also just in their by their very nature sustainable practices. So now these I'm going to leave because I think these will come up in our discussions hopefully later, but I think there are a number of other concepts that are sort of complementary and compatible between engagement and sustainability, and I look forward to those discussions. And most of all, thank you for listening to all of this talking. And hopefully now we can have you guys ask some questions, and I look forward to discussions after.
So we have time for a few questions. I'm really, actually,
Sure. Anyone? Oh,
and we need the mics just so that this works for filming.
okay, right.
Hello, hi. Thank you very much from a fellow patient to another. Thank you for your presentation. Very important not only to focus on the sustainability part of our healthcare, I think every human being should care about that, but also to think that a healthier person will have a better frame of mind to think, like I'm thinking of an 80-year-old living without pain, moving on their own. They might have a better mindset to care about the environment. So what I, as a patient, what I talk about is the DALI and CALI measurements, which is disability added life years versus quality added life years. So what I would like to see as a patient built into the environment of me having to interact, not by choice, with a healthcare system, is that in that 11 minutes that I have with my healthcare provider, that interaction is focusing on what I need, not just the one visit, one issue kind of situation. Because then, when I have a meaningful interaction, that 11 minutes may mean that after this wonderful surgery that I have took me out of a wheelchair, it may mean that if my questions are answered, I may go back and walk and maybe work and maybe pay taxes and save the environment. Or it may mean that I don't receive the proper care that I need and go back to the wheelchair, living on disability, and all of you, thank you, paying for my living. And I won't have even the joy of contributing to save the environment. Yeah. So it's important to think that that interaction with patients is not just that allotted 11 minutes that Ontario Health has given us, but also how can we listen to the patient because we know where the problems are. We're asking for how can we work together in this long walk that is chronic illness.
Thank you. Thanks. I think that's an important point, and one of the things that I think I probably didn't sort of say around the hierarchy of needs is that the more we support people to move out of those lower stages and into a space where even if they have a chronic disease, they are managing and able to meet their needs beyond those very primary basic things so that they're considering things like, what's my quality of life say? What are the things I want to do that make me feel well enough to have consideration at the level of things like environment and sustainability and those things? And I think that's where this really important concept of moving towards a preventative healthcare system and a system which empowers people to be self-managing actually by subsequently or as part of that supports sustainable choices, because those choices are very hard to make if, like you said, you don't feel supported to have those very basic needs met. At the back, yeah.
Thank you so much for your talk. I'm just wondering, Rachel said in the earlier talk about really looking for leadership as something that will help us move forward. As patients, sometimes sitting in our own home behind our own computer, what leadership do you think we should be looking towards to move this forward? Hospital leadership, municipal governments, where do you think our leadership or our questions to leadership should be directed at?
Okay, so maybe two there. I would say our leadership definitely needs to be coming from, I think because historically the leadership has come very much from a systemic level and from an expert level, I think there does need to, before things balance out, I think there does need to be a push from the side of patients and caregivers and people with lived experience to kind of have a chance to maybe have a louder voice in terms of who those leaders should be. I actually don't feel like I'm the one to decide. I think that I'm still learning myself. I don't necessarily even like the idea that there should be like 3 leaders who are leading, because by nature, learning from people with lived experience is about that collaboration and that equitable ability to have a voice. Now, I can see arguments against that. Now, who we should direct it to, I think one of the interesting things is we probably direct it at the people we are the most angry at, or that we see the most regularly, or that we, but I think what we need to do is look at how does actual engagement affect things like policy that are actually going to shift institutions and how things are done. And I think that how we map that is one of the really difficult things. How do we know whether it was the engagement or how those people with lived experience had an effect? And I think we need to look more critically at what those mechanisms are, and also be willing to try a little bit more and see what's sort of working and what's not. But I see sort of policy and beyond just individual projects being still the next level. Now, we do a lot of sort of town halls and but I think learning a bit more about like how to get people actually integrated into what policy work is, and have people also be educated much more about those systems that I think Rachel mentioned before, that we take for granted that people won't get it. well, don't talk about that. They just won't understand. For instance, transparency around certain financial details or connections to drug, whatever it is. We kind of have an assumption that people won't get it, they don't have the context, well, we need to do more to provide that context and that learning so that people can engage and understand. So that was kind of a non-answer, but I do think that definitely much more at institutional change as opposed to, I do a lot of work right now, it feels still on project-based change. One more quick one? One more quick question. A quick one.
I'm back.
She's back.
So what if I told you there's an evidence-based model right now that will support us driving accountability through like the pathway of healthcare providers through like continuing medical education, and also providing a channel for patients to be more engaged, rewarded for that engagement, and incentivized on top of that. But the caveat is that you'd have to be willing to engage with your genetics and support a preventative health model through a genetic profile that would support you in being cooperative and compliant to that genetic.
Yeah. And I think this is something which is really another interesting topic, which is around healthcare data and who owns it and what we're doing in terms of personalized medicine. I will say I'm very against thinking of things as being sort of panaceas for any healthcare system. I don't think we'll ever find the thing which will solve it, but I do think that these are all going to be important key components of being able to be engaged and to receive the care, to this point specifically around genetics, receive the care we need at the right time in the right place. I am not particularly well versed in the science of it, I suppose, but I think that there's opportunities to explore all of these areas. Again, I think that might be a great question for the tables as well. So on that, I will say thank you, and maybe we can chat after again. You can chat with both Rachel and I about it. And to say also, thank you guys so much for being here today and being interested in this. This is what gives me kind of really positive feelings about the future of sustainable healthcare, is that this many people showed up midday for free lunch. Wait a sec, maybe I'm not that impressed. But thank you again for having me, and I look forward to meeting some of you after.
So what a fascinating set of topics, what a range of really challenging and interesting issues to discuss. Now is the time for a break. You've got just till 2:30 when we hope you'll be back in your tables for an hour and 15 minutes of breakout discussion. Thanks so much.
Hi, Shalom.
Oh my God.